We're about to get started. Good afternoon, and welcome to our final budget hearing. All right, well, y'all can stay next week too then. All right. No, I'm joking. We're grateful to have the Department of Health and the Department of Drug and Alcohol Programs here with us this afternoon. Before we begin, Chairman Struzzi, any introductory comments?
Yes, thank you, Chairman Harris. Good afternoon, everyone. Welcome. You'll see happy faces this afternoon, I'm sure. Just for an overview of the current proposal from the governor for your department for the upcoming fiscal year of 26-27, he is proposing a $260.3 million budget, an increase of about $740,000 or just 0.3% over the current fiscal year, with about $48 million for the Department of Drug and Alcohol Programs, an increase of $30,000 or 0.1% over the current fiscal year. Obviously, a lot of things to discuss today related to health care, and so we will go ahead and get started. Thank you.
Thank you, gentlemen. In the middle of the table is our timekeeper. When the light turns green, members will have 5 minutes to ask questions. When it turns yellow, that means 30 seconds are left, and when it turns red, that means time has expired. We will ask that you would wrap up your comments, and they would wrap up their questions as well. Before we begin, we have our testifiers stand up so we can swear everybody in. Do you solemnly swear that the testimony you're about to give is the whole truth, so help you God? Okay, you may be seated. You ready? We're going to start with Chairman Frankel.
Our opening?
My bad. I'm sorry. Do you have opening statements?
Yes.
Okay, we'll commence with the opening statements first.
Thank you so much. Good afternoon, Chairman Harris, Chairman Struzzi, and members of the House Appropriations Committee. Thank you for this opportunity to discuss the proposed fiscal year 2026-27 budget for the Department of Health. I'm joined here by Executive Deputy Secretary Kristen Rodak. This budget supports the health of Pennsylvanians with funding to continue improving outcomes for mothers, children, and families, investing in health research, boosting emergency medical services, and addressing critical healthcare workforce needs, especially in rural areas. In short, this is a common-sense, balanced budget for Pennsylvanians. It's been a busy year for us at the Department of Health. Last year, with investments made by the General Assembly, we were able to, among many other things outlined in my written testimony, continue support for regional maternal health coalitions to improve care for mothers and babies, provide equipment and training to support EMS professionals as they responded to calls from more than 2.2 million Pennsylvanians, and coordinate with local, county, and state partners to efficiently respond to more than 20 emergency situations, including the recent fire at Lehigh Valley Health Center in Dixon City and the explosion at Bristol Health and Rehab Center in Bucks County. The proposed 26-27 budget will allow the department to continue to focus on improvements in many areas of public health and safety, including improving maternal and child health with a focus on preventing infant deaths, investing in neurodegenerative research to find new treatments and cures for this generation and for generations to come, providing period products in schools so students can stay in class and focus on their education, and continuing to support EMS professionals across the state. I look forward to working with all of you to implement this sound budget proposal that enhances the health and well-being of all Pennsylvanians. And I'm happy to answer your questions, but first I'll turn things over to my colleague and friend, Dr. Latika Davis-Jones.
Thank you, Dr. Bogan. Good afternoon. Thank you, Chairman Harris, Chairman Struzzi, and distinguished members of the House Appropriations Committee for the opportunity to be here today. With me is our Deputy Secretary, Kelly Primus. As Secretary, I serve at the pleasure of Governor Shapiro and all Pennsylvanians, especially those struggling or have a family member or loved one struggling with a substance use or gambling disorder. Throughout the next few hours, I am confident that you will hear about the accomplishments of DDAP that we've made throughout the last year and how we're building on the progress made since the beginning of this administration. At DDAP, we believe that Pennsylvanians living with a substance use disorder deserves access to high-quality treatment no matter where they live, and that treatment and services can be a vital first step on the path to recovery. Governor Shapiro's proposed budget supports that mission. His blueprint for the next fiscal year recognizes our commitment to providing quality services for those that need it the most, especially in terms of prevention. Prevention really is the first line of defense in stopping a substance use disorder from developing. Through the governor's proposed budget, we have the opportunity to expand our prevention efforts in schools, literally meeting children where they are at. This would pay dividends in the future in having a healthier, safer Commonwealth. With that, please know that I invite all of you to help us achieve our goals, whether we're talking about prevention, intervention, treatment, or recovery. I look forward to partnering with you in these efforts. Thank you.
Thank you. Now, Chairman Frankel.
Thank you, and thank you, Dr. Bogan and Dr. Davis-Jones. Really appreciate you. First of all, thank you for all you do, keeping Pennsylvanians safe and healthy as we see all the chaos and fantasy medicine and science coming out of Washington. The work you do is more important than ever. I wanted to talk a little bit about cannabis and particularly the medical marijuana program and the testing. In November of last year, researchers published an article in the Journal of Clinical Infectious Diseases showing that a Pennsylvania cancer patient's medical marijuana was the source of the infection that killed her. She was a medical marijuana patient with a medical marijuana card, buying approved medical marijuana from a licensed medical marijuana dispensary. But the cannabis she consumed contained Cryptococcus neoformans, a fungus that turned out to be deadly, and she died. We know that medical marijuana was responsible because researchers used whole genome sequencing to prove it. My office spoke with the researcher after the article was published in November of last year, and what she said she wants is the same thing I hear that patients want generally, and that's reputable lab operators want the Department of Health oversight for the laboratories that are required to test medical marijuana and ensure that it's free from deadly mold, bacteria, or heavy metals. What power does the department need to stop another medical marijuana patient from dying from products that they believe are safe?
Thank you so much for that question about our program, our medical marijuana program. You know, the Department of Health is tasked with ensuring safety for our program and access to safe medications for patients who need it. Again, this is a medical program, so the people who receive these have underlying health conditions, cancer, seizure disorders, and other things. We're certainly aware of the nationwide concern around lab and lab oversight, the issues of THC inflation, saying the products have higher rates of THC than they do, passing products that don't meet strict regulatory requirements. So it's essential that all of our labs that are certified follow the best policies and practices to ensure patient safety. These labs are really the last stop before the product gets to people, and so we want to make sure that they're doing their job and that they're doing it well. I think we really look forward to talking with you all on what statutory and regulatory options we have out there to ensure that we have the safest products out there. And so look forward to working with you on potential opportunities.
And we have a bill that we sent out of the House, is sitting in the Senate now, House Bill 33, which will help, I think, give us a more robust testing agenda for the state. Let me turn to something else that was actually brought to my attention. I spoke to Dan Myers about it earlier. It came to my attention that we have a health quality initiative that was federally funded by COVID dollars to the tune of about $25–30 million that would be available to the Commonwealth. And this was before your tenure, obviously, as Secretary of Health. And that would provide free, high-quality, portable air purifiers to mitigate the spread of COVID, influenza, bacteria, mold, and other airborne pathogens. The program is run through DOH, and there's money that's there that may have to be turned back to the federal government if it's not used, and it hasn't been publicized for a while. It seemed to me that it's really an opportunity, I think, still before we have to turn back what looks like about somewhere between $12 and $15 million to be able to kind of reinvigorate it. And I think it would be something that members of the General Assembly would be, very interested in being able to take back to their districts as opportunities to get these air purifiers out. And I was hoping you guys might be able to help facilitate that and to maybe reinvigorate the opportunity to publicize this.
Sure. Let me tell you a little bit about that program. So as you stated, during the pandemic, it became really discussed widely that HEPA filters are a way to reduce airborne spread of infections, particularly respiratory infections. And so we had COVID funding that we have been using to purchase and distribute HEPA filters to particular types of organizations, to child care programs, to senior centers, to libraries, to schools. And I believe we've distributed about 17,000 of those this year. And that program, the funding is going to be ending soon. And so we're happy to talk with you afterwards, but the program has been out, and we did reach out to many, many organizations across the state that met our criteria for eligibility. But happy to discuss with you after.
I think our members would be glad to help, get that message out and those opportunities out to organizations in our district. So thanks so much. Appreciate it.
Chair thanks the gentleman and recognizes Chairman Gillen.
Thank you to the testifiers. Appreciate you being here. And I'll keep my questions truncated given the lateness of the appropriations hearings through these last couple weeks. If I were to Google EMS in Pennsylvania, there's another word that pops up, and that would be crisis. Secretary, would you characterize the EMS system in crisis today as well?
EMS faces a number of challenges. They face financial challenges and reimbursement. The current system really for EMS is funded through a variety of sources, the MSOF fund as well as billing for services. The problem is that readiness isn't really well funded, and they spend a lot of their time being ready and responding to things where they don't get reimbursed. So for instance, there's a house fire and the ambulance sits there waiting to see if anybody needs emergency care, and they spend 2 or 3 hours there and they don't transport anyone. That's not reimbursed. So financially, there are some challenges. They certainly have a lot of challenges around workforce. We've been working a lot on addressing workforce issues and providing support and reimbursing people for their training. But again, lots more work to do on workforce. And I think that there are opportunities for all of us to work together on some regulatory reform as well. So yes, I think we have a lot of work ahead, but we are making progress.
Are you optimistic that funding help is on the way, either a Medicare reimbursement, insurance reimbursement changes? I know there's some products out there, House Bill 1152. Are you, as an administrator, embracing anything in particular?
There have been some changes already. As you know, the reimbursement through Medicaid changed over the last year and increased rates. They also started to pay for the first loaded mile, not waiting until they got to certain distances. I think there's, again, more opportunity. We have been making sure that the MSOF funds are getting out and distributed, and we added an extra $6 million this year in MSOF funds to EMS regional councils to get out to agencies for equipment and training. But again, there's certainly more opportunity to look at the funding mechanisms and for reimbursement. Lots of opportunity.
I was an EMT for 30 years. I have my own ideas about high turnover. In terms of your perspective, why are we seeing such high turnover?
Turnover amongst EMS providers?
Yeah, paramedics, EMTs.
Yeah, it's a great question. Again, it's a stressful job, as you know, having done it. It's 24/7. It's out in the rain and the sleet, and it's not like we have the most amazing weather year-round in Pennsylvania, so you're out delivering services. So it's a tough job. Reimbursement and the salaries are relatively low compared to other specialties that do that work. So again, I think there's lots of opportunity. I think the other thing is we know that there are a lot of people who get their EMT or their license and then they go on to something else, which is great for them, right? They get trained, they do it for a couple of years, and they see it as a stepping stone to another field. So I think we have to figure out how we make sure that there are ways to rise in the field. And so I'm happy to talk with you about what you think we can do to improve that.
Yeah, you're right. People do move from EMTs to less stressful jobs. I made a mistake of going into the legislature thinking it would be less stressful.
They don't call you at 2 in the morning to get out of bed, do they?
And just finally, in terms of recruitment, have you found any particular approach to be more efficacious than others drawing people into the field?
You know, we've been working a lot with our regional councils on training and opportunities. So we have the summer camps where we've gotten high school students interested. You know, when I go around the state and I talk to people in all kinds of fields and I say, like, what got you to go to a long-term care facility and work in a long-term care facility? What got you to go into EMS? It's often their experiences as a young person that drives their interest later. So I think, again, making sure that people know about the field and the opportunities. I know that, for instance, we were at the farm show with an ambulance last year, and people like really were interested in walking in, seeing what it was like. So how do we make sure that we provide experiences so our young people know that these are opportunities for them for that work? I think it's harder as people age to make that interest grow.
Thank you for taking those steps, Secretary. Thank you, Mr. Chairman.
Chair thanks the gentleman and recognizes Chairman Williams.
Mr. Chairman, thank you. And Dr. Jones, Dr. Bogan, as well as your staff, thank you for the critical work that you do. Let me begin by asking you these questions. The recent drug surveillance report actually showed an increase in overdose deaths involving stimulants. Can you talk about the factors that you think are contributing to that rise, and then what strategies might be able to address it?
Thank you for the question. I'll start by saying that we know, as it relates to our drug supply and what people are being admitted to treatment for, stimulants is one of the top three, right? We're talking about alcohol, followed by opioids, and then also stimulants. And so what we're doing is ensuring that across the Commonwealth that people have access to the care that they need. And we're ensuring that underrepresented communities across the Commonwealth that they have access as well. And so some of the things that we've done is expanding mobile units across the Commonwealth. For this past fiscal year, we were able to bring on 2 additional units, so now we have 4. So again, making sure that people have access to care when and where they need it. In addition to that, we've also expanded telehealth options across the Commonwealth. We have a telehealth-only license here in the Commonwealth now. Last year, I think we were at 1 or 2. We now have 5 telehealth-only providers. And again, that's an opportunity to expand access for those that may not be able to go into a physical location. So again, ensuring that people, when they need access to the care, whether it be for an opioid use disorder or stimulants, that we have services available. And then once they leave formal treatment, we want to make sure that we have recovery support services in place as well. We need recovery support services to help them along their journey. And so that's some of the work that's happening within our department. Dr. B, do you have anything else to add?
I think she covered that, yeah.
No, I appreciate that response. Secondarily, we're also seeing an increase in emerging intoxicating substances, including new synthetic opioids, synthetic kratom products, synthetic cannabinoids. Can you talk about the steps the department is taking to monitor and respond to those substances? And then secondarily, what actions do you think this legislature might be able to consider to help ensure they're not reaching consumers, particularly when they're being sold through storefront retailers?
Do you want me to start with this? Sure. Appreciate that question about these unregulated intoxicants, as we could have lumped them all together. And they are a growing problem across the state, as you identified. We have regulation and enforcement challenges around them because they come from a variety of things. Some are plant-based, sold in, as you say, convenience stores. The Department of Health's role really is on tracking and surveillance and education. And so we have been working diligently trying to make sure we provide education. And I think part of the challenge is that we run the medical marijuana program, and that is regulated and overseen, and the products are tested, and people confuse those with the unregulated market. And that has been a challenge. So when someone shows up in an emergency department, we're not necessarily knowing whether they are using an unregulated product or what. And then tracking them has been very hard. But the Department of Health really is working on tracking and surveillance and a lot around education. And we're also working together as an administration. So we have a committee. We are meeting regularly to talk about how do we as an administration really respond to this more broadly. And I'm sure Dr. Davis-Jones would like to add to that.
And I'll just pick up from right there. The committee that Dr. Bogan is referencing is our intra-agency substance use response team. And we are convening agencies, again, across the Shapiro administration to examine intoxicating hemp derivatives and other products sold at gas stations and throughout Pennsylvania. We do recognize that these products are totally unregulated at this point under the current law, and we're making some serious inquiries about what we might do in the future. And so we've been meeting over the past, I want to say maybe 6 to 8 weeks, taking a deep dive, looking at what's out there and what we may be doing in the future. And so we want to make sure that when we move forward that there is public awareness and that there's transparency about these products that are in convenience stores across the Commonwealth. So it's a work in progress.
Can I add one more thing? You know, the hemp loophole that's being closed on hemp products doesn't go into effect till this fall. But there's a whole lot of other products that don't fall under that hemp loophole as well that are another class of unregulated. So again, it's a very broad topic that we need to really work with you all on how we rein in access to these products.
Listen, I appreciate your responses. My time has expired. Thank you, Mr. Chairman.
Chair thanks the gentleman and recognizes Chairman Heffley.
Thank you. And I guess the question will more or less be for Dr. Latika Jones. The DDAP. DDAP has oversight over recovery houses and making sure that they're compliant with federal, state, and local laws. What steps does DDAP take right now to ensure that recovery houses, and we worked on legislation a few years ago regarding recovery houses, what steps do they take right now to ensure that there's compliance with those local ordinances?
Yeah, what I will say, as you all know, DDAP's recovery housing licensure program is just one more tool in our toolbox to ensure that all Pennsylvanians across the Commonwealth have access to supported housing. Recovery housing is not treatment. We just want to make sure that we call that out. But it is a house where they receive mutual support from their substance use disorder. The department we currently license recovery houses, and we license recovery houses that are open to receiving state and federal funding. When you talk about occupancy and local ordinances, we do not have any skin in the game from that perspective, but we do require recovery houses to attest to the fact that they are in compliance with local laws and ordinances. And so we license, and we license against our regulations.
So pursuant to the current law, it does state that DDAP must make sure that these recovery houses are in compliance with federal, state, and local ordinances.
And we do that through an attestation process.
We also work with local communities when they have issues and present them to us. For example, whether it be occupancy or zoning, if they would come to us about that attestation, we would certainly work with them and provide them what they need. We believe that we understand substance use disorders and what people need in terms of treatment and support, and that's what we focus on to ensure safety, person's financials, and their rights are protected in a recovery house, and we allow the experts, which are the local municipalities and authorities, to focus on the implementation and monitoring of things such as zoning and occupancy.
Yeah, just want to make sure that when people are living in these facilities, that they're being compliant, that we're overseeing that local compliance, because a lot of that local sometimes comes down to fire safety, other safety. I know there's been an issue, and just to move on, because I have one more round here, one more thing.
Okay. I was going to add something else, but I'll let you go.
Okay. Well, I know it's an ongoing discussion. I just wanted to shed some light on that, why it's important, because at the end of the day, you guys are that oversight. But one thing I did want to touch on is I'm hearing from some of our providers that payments may be delayed. And we talked a little bit about, I mean, every hearing we have, we talk about worker shortages, provider shortages, and coming from a rural county, that's very real. And one of the reasons is pay and some of the other things that go along with that. But when we look at things being delayed due to issues with DDAP revising and executing the funding agreements with single county or SCA, single county authorities, what is the department doing to expedite this process to ensure that the money flows to these counties in a timely manner? Because they generally do not have reserve funds to back this up.
Absolutely. And I will just say that the delays in processing some of our grant agreements are the result of multiple factors, including the Commonwealth budget impasse along with the federal government shutdown. But what I can assure you is that we are working diligently to get those contracts out the door. What I will say, we are ensuring that, and as of today, I think, what was the number, Kelly? Do you recall the number that we had?
There are 30 waiting at the comptroller. There are 30.
Yes, there's 30 right now at the comptrollers ready to be sent to single county authorities. And so what I will say, we've worked really hard to get those done. We recognize that SCAs do need their contracts, and that in order to bill us, they have to have an executed grant agreement. So we are continuing to get those out the door, and we're hoping within the next couple of weeks, those SCAs will have their grant agreements.
Yeah, so that's the other question is with the executing this 5-year agreement and that interruption, that is resulting in interruption of cash flow at the end of the calendar year. And some providers are fearful that they may not be reimbursed for services between July and December of 2025 if the invoice wasn't submitted by the end of December. What would you say to providers? How are we going to resolve that? Because we have to have these providers reimbursed for those services they have already, provided.
Our goal is to ensure that the SCAs have their funding that is stated in their grant agreement, and as long as the SCA has their grant agreement and they invoice us for the services delivered, providers, from my understanding, should be able to be reimbursed. What we'll do is we can go back and really give you a more comprehensive response to your question. But what I will say, those contracts, I say contracts, but grant agreements are underway, and we do have the funding available to support our single county authorities. And as you know, those single county authorities contract with our provider networks across the Commonwealth, and they should be able to provide those reimbursements to our provider agencies.
Thank you, and we look forward to working with you on that and many other issues. Thank you for your time here today.
Thank you.
Chair thanks the gentleman and recognizes Representative Mays.
Thank you, Chair. Happy Women's History Month. Welcome, Dr. Bogan and Dr. Davis-Jones, for being here. Thank you for being here, and thank you for your continued leadership as we work to end the public health crisis of Black maternal health and maternal health across this Commonwealth. As co-chair of the Pennsylvania Black Maternal Health Caucus, we want to invite you and your team to Black Maternal Health Week at the Capitol, and everyone who can hear us, who is watching, we invite you to the Capitol April 13th and 14th as we celebrate, once again, Black Maternal Health Week. I want to talk to you about the Maternal Mortality Review Committee report that is now required to be released to the public every year, which is showing us the trends that are impacting moms across this Commonwealth. We know we continue to face racial disparities in maternal mortality and in maternal morbidity, and that across the board, maternal deaths are preventable. So in this most recent report, 98% of maternal deaths were preventable. In the previous year's report, it was 92% were preventable. So, Dr. Bogan, I just want to ask you, as much as we are continuing to invest here in our Commonwealth, we have had the greatest investments in maternal health and Black maternal health in our state budget. What's your assessment of what we can continue to do from here as we face a myriad of challenging and complex systemic issues that are contributing to the Black maternal mortality rate and the maternal mortality rate across the board? We love your insights, and we appreciate, again, all the interventions that you've already done, that we've done together. But what more can we do?
I appreciate that question a lot. As you said, you all, the General Assembly and the Governor, have really, for the first time since this administration, really put money to the issue that you're talking about. And that money is really, I think, we're just beginning to start to see the impact of that work. So that work has been funding regional maternal health coalitions that are identifying in each of their regions what is a pressing issue and how do we really implement the recommendations coming out of the Maternal Mortality Review Committee. And as you know, we've been working on a maternal health strategic plan with all of our sister agencies. And again, we have seen this money go out the door. So we are now seeing doulas that have been trained and are out in the community working. We are seeing people being screened for hypertension during pregnancy and after pregnancy, which is where we see a lot of the problems. We are seeing much greater rates of mental health screening amongst our providers. And all of those things, and really addressing screening for mental behavioral health and substance use, because we know that a lot of the preventable deaths relate to mental health and substance use disorder, and we really want to make sure that people are getting screened and referred to services and getting the services they need. And that's why it's important that all the agencies are doing this work. It's not one agency, it's really across all of us. So I think, again, the money has been going out the door over the last 2 years, but it's going to take time to see the impact on the mortality rate. But we are hopefully identifying people earlier and making sure they have the services they need. I think this is slow and steady work, and we need to continue what we're doing and not let up, right? We need to continue to make sure every person receives early prenatal care, gets the prenatal care they need. And we have challenges in that case. As you know, we have large swaths of the state where that is a real challenge. So we have a lot of work ahead of us, and I think our strategic plan that we're all working on together will help guide our pathway, but we need to keep that gas pedal down and really making sure we're not letting up. And I know the Drug and Alcohol Programs has also been working on maternal health issues. They fund the really great program. The
Perinatal Quality Collaborative.
Yes, the PAQC, which has been doing great work with all of our birthing facilities across the state. So I want to leave a minute for Dr. Davis-Jones to add if she would like.
Absolutely. And I'll just say that, our department is committed to ensuring that we have pregnancy support services across the Commonwealth. Right now, for this year's budget, upcoming budget, we have over $8 million slated to support pregnant women, women with children. and we will continue to expand services where necessary. While our minimum is 20% of our federal budget has to be sort of dedicated to that particular area, we are making sure that we are collaborating, whether it be in regards to plans of safe care, the strategic maternal health plan, along with supporting programs like the Baby Love program at Hamilton Health. We are continuing to do that work. So just know, as Dr. B just stated, the impact, it's going to take a little bit of time, but we have the resources and supports available, and we will be tracking and evaluating the effectiveness of our interventions.
Thank you both. Chair, could I have one more minute? Thank you so much. I appreciate that, and I want to turn to the Pennsylvania Mommy Bus, which is the legislative package that is groundbreaking in our vision of reversing the disturbing trends of maternal mortality and morbidity, that you've addressed some of the ways that we can continue to intervene. I do want to ask a specific question about two medical conditions I don't think are being uplifted enough, and my one bill, House Bill 1234, that addresses the coverage, Medicaid coverage for blood pressure monitors to address preeclampsia or high blood pressure, how important that is to moms and those who are pregnant in our Commonwealth, to make sure we're tracking their blood pressure throughout pregnancy, during labor, and in the postpartum period. I also want to ask you about the impact of cardiovascular or heart health, and how is that impacting maternal mortality and morbidity? So preeclampsia and cardiovascular health. What are you seeing in terms of how is that impacting moms across this Commonwealth, those who are about to give birth, those who are in that postpartum period?
Yeah, those are two really important contributors to both morbidity and mortality. So morbidity being more illness and postpartum. And so we do have a number of programs through the funding that we've already initiated to address blood pressure monitoring. So in the WIC program, in one of our areas, they've screened over 1,000 women for blood pressure. And if they're elevated, they've been giving them a blood pressure cuff and asking them to follow up and giving them lots of education. And I think about 10% of the women they've screened actually have had high blood pressure, and they've referred them on and provided education. So linking them to services is really important. I'll also point out that it's not just blood pressure during pregnancy, which is also very important, but it turns out that people can get postpartum hypertension that didn't even have it during pregnancy. So it's important to monitor after. And there are a number of programs that are happening in pediatric offices where they're screening mothers who come in, because we know that after the birth of a child, people tend to take their baby to pediatric care but don't necessarily get their own care. And so some of the pediatric practices are screening mothers as well for postpartum hypertension. So I think we need to, as a group, really make sure we understand that the breadth of this condition, the ways we can screen, and we need to make sure that mothers have the education that they know what the signs of hypertension and cardiovascular disease look like, so that they can seek care when they're having symptoms.
So thank you. The Pennsylvania Black Maternal Health Caucus, we will be unrelenting with you and your leadership roles to address Black maternal mortality and morbidity all across this Commonwealth. Thank you, Chair.
We look forward to working with you.
Chair, thanks. General Lady, Representative Brown.
Thank you, Chairman. Dr. Davis, I would like to talk to you about the opioid settlement funds. And I would like to know if you've entered into any multi-year contracts that go beyond the current fiscal year to provide that funding.
Multi-year?
Yes.
I do, yes, absolutely we have. Let me just get to my section in my binder. So to answer your question, yes, we have.
And do those contracts contain clauses that voids the contract in the event dollars are not appropriated in 2026, 27, or future planning years?
That's a good question.
We definitely have clauses that talk about being able to separate from whoever the grantee is. But in terms of appropriating, if the funds wouldn't be spent, we would have to reallocate them from that provider to another provider.
Okay, good. So in November, this chamber nearly passed unanimously House Bill 1528 to establish the Grand Family Assistance Program, of which I was proud to be one of the co-primes on with both of the chairpersons of the Aging Committee. And this is legislation that is so vital to our grandparents that are raising their grandchildren in our communities. And it's my understanding that your department had concerns with utilizing opioid settlement funding for this legislation because it was already committed for the out years. Is this correct?
We do have commitment for our opioid settlement funds. And just to level set, when you think about the opioid settlements, we know that 85% goes to counties and litigating subdivisions. 15% comes to the Commonwealth, and if appropriated by the General Assembly, then DDAP will get those funds. And so we have to plan for those funds when we receive them. So therefore, we've had several initiatives earmarked to receive opioid settlement funds. And so at the time that we were looking at the legislation, our thoughts were that that's where those funds are committed, and we were moving forward with those initiatives. And so there's always opportunity. We have said loud and clear that organizations and individuals can meet with all of the counties that are that do have a process in place that have a process in place to actually talk about the different kinds of initiatives that they want to fund. Some counties do proposals. They put out requests for proposals. Some of them have working committees.
Yes, and I'm aware of those, but respectfully, this problem is prevalent across the state, and again, it passed almost unanimously. So it's obvious it's a problem for the state. So is this legislation something you would reconsider?
We will definitely take it back to our department to have some discussions. I think we're always going to be open to have those discussions, most certainly.
Okay, we would greatly appreciate that. Thank you so much.
Yeah, definitely.
Thank the gentlelady, Representative Curry.
Thank you, Chairman. Hello and good afternoon. Happy Women's History Month. I'm here to talk about the devastating impact that maternal care deserts have in the Commonwealth right now. I currently have a bill that we're working on in the Momnibus 2.0, House Bill 432, which addresses maternal health deserts through maternal care access zones. 23 of Pennsylvania's 67 counties do not have a hospital that provides labor and delivery services. And all 23 of them are rural counties. For families in these areas, the average distance to the nearest hospital providing these services is about 27 miles. And unfortunately now I can say that in my own county, Delaware County. As maternity units continue to close or consolidate, timely access to care becomes even more critical to healthy pregnancies and births. What is the department's plan to address these maternal care deserts? And how are you working to ensure that expectant mothers in these communities can access the care they need close to home? And I have one more question, so can you answer that one first? Thanks.
Sure, I'll try to keep it short.
Okay.
Thank you for raising this important issue that certainly is worrying for all of us, right? You gave lots of statistics about the challenges facing people getting care across, particularly in rural Pennsylvania. The Department of Health really, it's not just the Department of Health issue, right? This is a statewide issue that we all need to address together. I think there are challenges in workforce that are driving some of this. There's also challenges in maintaining the cost of a maternity unit. So we need to think about how we fund these because, you know, to run a maternity unit, requirements are that you have to have 24/7 care. You need to have an operating room available. You need to have that available to be staffed. You need anesthesia care. You need to keep your staff trained, right? We want well-trained maternity units. So the way we currently fund that is challenging, and how you make, it's kind of an issue of readiness. And so I think we need to think strategically, how do we make sure that we fund those, that we have the workforce available to do that? We have a shortage of healthcare providers and nurses. So I think, again, I welcome all discussion on this. It is addressed, and I think part of our maternal health strategic plan addresses this, and I think the Rural Health Transformation Plan funding maternal health is certainly one of the goals of that work as well. So I think we have opportunities to use that funding.
There are definitely opportunities, and I think we've talked about mobile care units and vans. I think Representative Brown has often talked about her area where they have to go into other states to have babies, our neighboring state, and the mobile units are critical. I know they're expensive, but we need to start thinking about it, because the reports that we're getting are that women are having babies in ambulances, and then the care after that is not there. And so we talk about the Black maternal health disparities, but we're talking about all maternal care health at this point, because we don't want to continue to see moms die. And this is what's happening when we don't have that care. The other question that I wanted to say—
Rep. Curry?
Yeah, sure.
We wanted to add something to that conversation really quick.
Sure.
I'll be quick, I promise. In addition to what Secretary Bogan said, we've also been working on this issue and have done an environmental scan with 6 different counties, 2 of which are maternal healthcare deserts, and the others have limited access, and worked with them in the local counties to basically assess the situation and work towards solutioning and interventions, which we plan to work with both the Department of Health, the Department of Human Services, and OMAP together on that.
So we're looking for some additional solutions, and so they will be coming forth soon.
Thank you very much for that. And then hospital closures like Crozier Health have left entire communities with fewer local healthcare options. When a patient is transported to a hospital by EMS, the patient may have preference of which hospital to go to. Now, in my area, they don't really have that preference, but how does the department monitor these patterns and ensure that hospitals receive adequate support and resources? And I know we've been on calls about this. How's the department monitoring it?
I'm not sure. Can you clarify, your question is specifically about EMS?
I'm running out of time.
Yeah,
and I
that's
know,
okay.
Chairman. So basically, when somebody gets into an ambulance and they're like, take me to this hospital versus that hospital.
Yes. So EMS generally takes people to the closest hospital that can provide the service that they need. So that's the general rule. You get into an ambulance, you go to the nearest hospital. People can ask for a preference to go to a particular hospital, for instance, if that's where they get all their care and they know the doctor's there, or they recently had surgery at that hospital. So they can ask, but the EMS providers can say, look, that's not safe, we need to take you to the nearest hospital.
Well, I
What
thank
the
you,
EMS
Dr.
cannot
Bogan.
do- yeah.
I thank you, Dr. Bogan, because I'm getting the eye, but thank you to both of the departments for the great work that you're doing to help the caucus, and we appreciate all your work. Thank you, Chairman.
Representative Kale.
Thank you, Mr. Chairman. And I'm going to continue on this line of questioning so we can get more discussion. Before I do, Dr. Bogan, I just wanted to say, I love your earrings. I know I don't know if it's the color or what it is, but I just wanted to give a compliment first, starting
Thank you
things
for the
off.
this is from Costa Rica.
Okay.
The artists, I bought it at a little shop about 20 years ago, yes.
Okay, well, they're very nice, and I might have to get my wife a pair of them here. But I wanted to talk a little bit about rural health care. In my district, AHN is looking to, I'm not sure exactly what the technical term is, affiliate, merge, buy, however that works with Heritage Valley System. And we're very excited about this prospect because there was real concern that that hospital was not going to be able to function long-term because of their financial situation. With AHN coming in, we're excited that staple of the community is going to be there for years to come. But unfortunately, for far too many communities within our Commonwealth, in particular in the northern tier of the Commonwealth, that is not the case. So I wanted to ask a couple of questions with that backdrop in mind. The first is, my understanding is that the administration is looking to, is undertaking an effort to basically change the regulations within the community, hospital community. Can you give an update on how that process is going, and if you are looking in considering during that process the impacts it could have on rural hospitals and keeping them open?
Absolutely. So the hospital regulations in Pennsylvania are currently about 4 decades old. They're very old. And my understanding, long before I was at the department, back before 2020, they were being worked on. They kind of stalled during the 2020-22 period, and when we came here, we really picked that effort up. So because these regulations are so old and quite extensive, they do need to really have a close look. So we've been working really closely with stakeholder groups. We've been doing a lot of stakeholder engagement to understand what the needs are, and are drafting updated hospital regulations. I think it's really important. We're trying to make sure that the regulations have as much flexibility built into them as possible, because I think you and I both know that healthcare today is not what it's going to be 2 years from now, 6 months from now, right? There are changes, the rapidity with which it's happening. So our team's been working really hard with stakeholders, with HAP and other organizations on those. We continue that work, and we're hoping to have those out as proposed, hopefully in by next year. So we are working on those. But it is really about stakeholder engagement. But meanwhile, while that's happening, I think we have been working really hard on making sure we provide flexibilities where we can, right? If something's written into the act, that's the law. We can't change that. But we can make flexibilities if we can, and we have an exception process that we've used to try to make flexibilities. So we've put out a number of guidance documents last year that I think have tried to reduce the burden on hospitals around attestations for equipment, around physician coverage, and other things. So we are trying to do the best we can within the regulatory framework we have to be responsive and to be flexible. And we have been working with HAP and the rural hospitals. And I've been out to about 12 or 13 rural hospitals over the last couple of years, talking to their leadership on what are the things we can do right now to reduce the burden. But again, I think the ultimate issue is that we need to get those hospital regulations out there for major changes.
Okay, and a more particular question. Bradford County, the regional medical center there, announced that it was in fact closing, but there was a plan put forward to have a continuity of services going forward. And my understanding is they are waiting on an approval from your department. Could you give an update on that situation?
I don't know that they're waiting on anything from us. I'm happy to have a discussion offline to talk to you about that. I'm not aware of anything that they're waiting for on us at this moment. But again, I would be happy to talk with you afterwards about that particular hospital. Yeah.
And that's a more general matter. This issue with rural hospitals across the Commonwealth, hospitals shutting down, this has been hot for some time. And certainly since this administration has come in, what are some of the steps the administration has taken thus far? And what can we be doing as a legislature to help improve this situation?
Yes, our rural hospitals are struggling, and I think we have bumpy roads ahead because those hospitals rely very heavily on Medicaid, and as we know, there are some challenges ahead with Medicaid and funding, and the more uninsured people we have, the more challenging that will become. So I think we need to have a lot of dialogue about how we can work together to address what I see as ongoing challenges. But again, from the Department of Health standpoint, we are doing what we can around flexibilities, meeting with them, but I'm happy. I see our time is up, and I want to respect that this is the last hearing and you all want to get home. Yeah. So I will not carry on. But I'd be happy to be with you after the hearings to talk about how we can work together.
Thank you, Doctor. We can get something on the schedule. I appreciate it.
Thanks, gentlemen. Representative Mullins.
Thank you, Mr. Chairman, and to all of you, I appreciate you being here. It's good to see you. Secretary Bogan, it's great to be with you again. Last time we were together was out at the University of Pittsburgh meeting some some of those amazing researchers trying to find cures and therapies and treatments for some of our most devastating diseases. So I really appreciated you making the trip. I was with Chancellor Gable from Pitt yesterday and had a chance to hear the update on their end as far as research dollars go. As you know, we've taken important steps in recent years to address neurodegenerative diseases, including the creation of the first ever Alzheimer's dementia and related disorders division over in the Department of Aging, requiring insurance providers to cover biomarker testing for the benefit of earlier diagnoses and precision medicine, and most recently the allocation of $5 million to support neurodegenerative research. Just wonder if you could give an update on the status of that program. As you can imagine, these research institutions are excited about that funding and are anxious to put it to work.
Yes, thank you so much, and thank you for really supporting that, that funding. As you know, due to the delayed budget negotiations that happened, we really didn't know that we would have that funding to go out the door until late November. So we have been working diligently to get the RFP together. We expect that to be out soon, and for people to be able to apply for those funds quickly. So it's in the works. Our team has made it a priority. And again, it has to go through the process of putting the RFP out for those who are eligible to apply, and then for us to do grant agreements with them. So not out yet, but the RFP is on its way, and we'll be certainly happy to let you know as soon as it's posted.
Very good. That's
Thank you.
Very positive update, and I appreciate it. And the good news is the governor has yet again proposed it as a now recurring line item. So we'll be fighting for that on our end of the building. Switching gears, is a significant portion of your budget is supported by federal funds. But we've got programs like the Children's Health Insurance Program and smoking cessation that rely on tobacco settlement funds, but those dollars are on the decline. So I'm just considering, has the department considered, or can you comment on an increase in revenues from tobacco sales and vape products to help stabilize these critical programs?
Sure, yes. The Department of Health's budget is about 60% federal dollars. And of course, we've had some challenges with those federal dollars this past year. And so we are always looking at our opportunities for supporting our programs. Is there a specific question around funding? So you're right, the settlement dollars have gone down because the good news is the fewer people are smoking. And in Pennsylvania, we actually have more former smokers than we do current smokers, which is great, which is exactly what we want to do. So we continue to provide support around tobacco education, vape education, and really trying to discourage people from starting in the first place, really focused on teens. And always happy to discuss opportunities for additional funding for those programs because, as you can see, they've been impactful. And the fact that our smoking rates continue to decline speaks to that. So, but you're right, the way we currently fund that is through, it's kind of a catch-22, right? You're doing your good work, and so then your funding goes down. So again, happy to talk with you about opportunities for funding.
Thank you so much.
And we definitely have opportunities to collaborate because also within our department, we do have prevention programming. And so we need to think about how we might integrate some of our work to continue not only educating the community around, tobacco. We recently, as a part of some of our training series, we updated our training management system to include, I think, 3 or 4 additional tobacco cessation trainings. And so again, always opportunities to think about how we will continue to collaborate.
That's a great update. Really appreciate it. It always works out with you two testifying together because so your missions are very much intertwined. Thanks for your service.
Thank you.
Thank the gentleman, Representative Krupa.
Thank you, Mr. Chairman, and thank you all for being here this afternoon. I want to base my questions around the proposal to legalize marijuana. Much of that conversation focuses on projected tax revenue and economic opportunity, but what concerns me, particularly as a member of this committee and of the community at large, is The other side of that ledger, the public health impacts and the growing responsibilities that will fall on agencies like yours when it comes to addiction treatment, emergency care, and prevention efforts. The Pennsylvania Department of Health will be responsible for tracking increases in emergency room visits, accidental poisonings in children, impaired driving injuries, and maternal and fetal health risks. At the same time, the Pennsylvania Department of Drug and Alcohol Programs will face the reality of increased cannabis dependency, expanded treatment needs, and growing demand for prevention services, particularly among young people. We already know that today's marijuana products are far more potent than what existed decades ago. We know that edible products are frequently mistaken for candy by children. We know that regular marijuana use is associated with mental health complications, including anxiety, depression, and psychosis in vulnerable individuals. And yet, as lawmakers, and when we debate legalization, we rarely talk about the real question that should concern everybody, not just this committee. What these policies would mean for the agencies tasked with protecting the health and safety of Pennsylvanians. So I want to focus my questions today on those practical implications and what legalization would mean for your departments and the challenges you would face. And I have separated them into two buckets, so I'll start, Secretary Bogan, with you, if that's okay. If the recreational marijuana is legalized, the Department of Health would likely be responsible for monitoring the range of public health outcomes, including increased emergency room visits related to marijuana intoxication, the accidental ingestion by children from the edible products, potential mental health complications linked to high-potency THC, and all the conversations we had today about maternal health. We know that there will be issues with maternal health and fetal health impacts related to prenatal exposure. And then there's going to be other marijuana-related hospitals. What new systems, staffing, or resources would the department need to properly track and respond to those public health issues? Does your current budget or your requested budget account for those increased in services?
Thank you for that question about the adult use. Again, the department currently runs the medical program, and so we have resources from our medical program, and we've learned a lot from our medical program about proper labeling, packaging, trying to really keep things away from children to make them uninterested. So we can learn from all those lessons, and we can use the expertise we have. In terms of surveillance, our department does a lot of surveillance around infectious diseases, emergency department visits. So we have the experience and the know-how in the department to continue to expand that surveillance, particularly around emergency department utilization. We work very closely with the poison control centers across the state on surveillance. So again, we have the expertise on surveillance already in the department.
From a workforce perspective, how would legalization affect the department's ability to maintain drug-free workplace standards, and whether would marijuana legalization complicate employee drug testing or policies or workplace impairment standards for state employees in that setting?
I think that's a question more for our HR teams than for us.
Okay. Pivoting then to Secretary Davis Jones, and these are questions that I think we could take days to shift through. But research indicates that roughly 1 in 3 marijuana users may develop some type of cannabis dependency. If recreational marijuana were legalized, what increase in cannabis use disorder cases does DDAP anticipate? And does Pennsylvania currently have sufficient treatment capacity to absorb that potential increase?
Thank you for the question. I'll just start by saying with legal, illegal, or illicit substances, the Department of Drug and Alcohol Programs' mission remains, and that is to provide treatment, case management, and recovery support services for individuals throughout the Commonwealth should they develop a substance use disorder. And so when you think about this from the perspective of us tracking, the prevalence of what may come to be, at this point in time, we haven't been tracking where that may go. But what I will say, we're always ensuring that across the Commonwealth with our single county authorities that we are doing needs assessments, and we're also developing prevention plans with our single county authorities. And so the great thing about that is that each of those single county authorities, also our local drug and alcohol offices. They have the opportunity to truly understand what's happening in their geographical locations. And so by developing needs assessments, developing those prevention plans, they will be able to earmark funding not only for prevention, treatment, and other recovery support services. In addition to that, we do work hand in hand with our drug and alcohol offices, and should there be the need for additional funding, we do have the opportunity currently in place where single county, I keep saying single county authorities or our local drug and alcohol offices, they do have the ability to ask for additional resources, and should we find that our resources aren't able to handle the demand for treatment, of course, we'll be advocating for additional funds.
Thank you. I would love to ask more questions, but the chairman's going to throw a flag at me then, too. Thank you.
Thank the gentlelady. Representative Kincaid.
Thank you, Mr. Chairman. I want to sort of follow up on what Chair Williams was asking about in terms of kratom. You know, it's a growing problem, and it's something that I've had a number of constituents come to me and talk about the overdose issues that their children have experienced, and largely because kratom is easily accessible. The first time I saw kratom, it was sitting next to a pack of gum at a convenience store in a hotel. I find that incredibly problematic, especially given the 7-OH synthetic aspects. So, Dr. Davis-Jones, I kind of want to follow up with what you were just talking about. So a number of these constituents have actually talked about trying to get their children into treatment and then being rejected because kratom is not a serious enough substance for them to receive treatment. Can you kind of explain that, or what is it that we could be doing to make sure that kratom is a substance that we can be treated for?
Part of that is education, and that's what we've been talking about with our interagency substance use response team. You know, there's this piece around public awareness, training. We also do have to, ensure that our workforce, our healthcare providers, whether it be in hospital settings and within drug and alcohol treatment facilities, that they are appropriately trained and equipped to address intoxicating hemp products, right? And so, again, we are exploring our options, but we recognize that this is an important issue, and we will be developing a Commonwealth-wide response to addressing this.
Thank you. I think intoxicating hemp is really important to address as well, but that's not what kratom is. And actually that segues well into my next question, which is we are seeing a lot of substances become available, intoxicating substances from natural products that are in this legal gray area where there is no regulation, there is no control, and we can regulate intoxicating hemp, we can regulate kratom, but is there something more that we could be doing to ensure that we are catching more of these legal substances that are in this gray area to prevent them from becoming issues like kratom, like intoxicating hemp?
I hear you. I have similar concerns, right? It's a little bit like playing whack-a-mole. You get one down, you get another one coming up. I think really we need to make sure that everyone understands what they're purchasing, right? And there's a market out there that's extensive. So I think for us, the Department of Health really focuses on education. So how do we make sure that people know what are the potential effects of this? How do we make sure that people are smart about what they're exposing themselves to, and making sure that parents understand where and how their children can purchase these products, and we want to keep them out of the hands of children. So again, I think we have a lot of work ahead of us. I don't have any magic solutions, but I think we need to make sure that it is part of education and widely discussed, and that it's not kind of this behind-the-scenes thing that we all need to face. Like you can walk into a store and there's a variety of unregulated products, and we don't know, you don't even know if what they say is on the label is actually what's in the container. That's how unregulated they are. So share your concerns, and love to have some more conversations about how we can work together, because I think there's not one solution to this. It really is going to take all of us kind of working together to figure out how do we reduce this. But again, it's definitely a concern for all of us here.
Yeah, I mean, I think to your point, it is like whack-a-mole, and I think there has to be a way that we can get ahead of this so that we are not constantly responding to the next, gray area legal substance that's available to kids until we finally legislate to a place that it actually is regulated, has to be behind the counter, you need an ID to buy it, that kind of stuff. And so I would love to work with both of you to figure out how it is that we do that, because I think that there is a place for these substances if you use them responsibly, if you as a consumer know what it is that you're ingesting. So thank you, Mr. Chairman.
Thank you.
Thank the gentlelady, Representative Alsomer.
Thank you, Mr. Chairman. This first question is for you. Just wondering if Chairman Struzzi gets a red flag since you have the yellow flag. So, Secretaries, it's great to see you here this afternoon, and my question is for Dr. Bogan. And before I get into it, I want to thank you for all your help with the Pike County Micro Hospital, setting us up on the right path, you and your team, and our stakeholders and local officials to get on the right path right in the beginning. Things are progressing there. And if I have a chance at the end, I'll circle back to that. But Madam Secretary, we continue to hear from nursing facilities across the state about challenges with the department's staffing mandates and the associated impacts amid ongoing workforce shortages, including worsening hospital discharge delays. We hear from hospitals and nursing facilities alike on the strain this puts on the healthcare continuum. While well-intended, do you agree that these regulations are a barrier to accessing post-acute care?
I appreciate that question. We've been doing a lot of work on our long-term care facilities and really working on quality of care. So the long-term care regulations passed in 2022. I started in 2023 as they were being implemented. And in the first year, we heard a lot of concerns about staffing and issues with staffing. And I will say that we've been tracking as we go out for our surveys to see how we're doing around staffing. And I'm happy to report, actually, that we have most of the facilities are not having staffing challenges in terms of meeting the regulations. And the facilities that seem to be having staffing challenges are also the ones in general that are not meeting other of our regulations. And so it does mean that some facilities have reduced the number of people in the facilities so that they can meet the staffing. But again, you and I want to make sure that when we drop off our loved ones at a skilled nursing facility, that they get quality of care. And this really is an issue of quality, ensuring quality of care. And these staffing ratios have been demonstrated, or these staffing requirements have been demonstrated to really make sure that people are getting the care they need. We have not heard about delays in the last year around hospital discharges. The ones we have looked into around those delays actually turn out to be more insurance-related than staffing-related. And so if you're hearing specific hospitals having discharges that are related specifically to staffing in long-term care, I'd love to have a conversation about that. But we have been tracking really closely through our survey process what has been the impact. And again, I'm thrilled to say that the facilities are meeting the regulations for the most part. And again, we are working, my focus and my team's focus is really on ensuring quality of care in our long-term care facilities, and staffing appropriately is part of that quality issue. But again, if you're hearing specific ones, I'd be happy to discuss that with you, because we want to make sure that we are meeting the needs of Pennsylvanians.
If I could just add one thing. I think the other factor, in addition to what Secretary Bogan mentioned about quality for patients, is really quality for the workers. I know you had mentioned concerns about workforce. We all know that there's concerns about the workforce structure within our Commonwealth for healthcare, but adequate staffing is really helpful to keep the workforce and make sure that they know what they're doing, they're trained, they have support when they need it. So actually part of the reasoning for the staffing requirements in the long-term care facilities was actually for staff quality and really to make sure that their work balance was appropriate. So I just wanted to also mention that part because I think it's important.
And you did. You know, when these regulations were enacted, you did state that it would increase the quality of care. So do you have any data to support the claim, and can you provide that to the committee? I know, do you have concrete data of that?
We have data on the numbers of facilities that are not meeting regulations when we visit and working with them on that. And yes, we have that kind of data. Around whether people, the impact on the workforce, I can tell you that we did, our long-term care transformation office funded quality investment pilot projects. And one of the goals of those projects, it went to about 100 facilities across the Commonwealth, small amounts of money. A big focus of that was on workforce training and support. And what we saw, we did an analysis through an independent evaluator and determined that actually the folks that got this small amount of money focused on workforce actually saw less use of contracted staff, more regular, way less turnover in their staff, and consistency. And we know consistency in staff actually is also really important. So we have that data. We put out a short report about that. I'm happy to share that about the importance of really making sure that your workforce is cared for and how small differences can really amplify the impact and quality.
Thank you, Madam Secretary. Thank you, Mr. Chairman.
Thank the gentleman. Representative Salisbury.
Thank you, Chairman. Today I'd like to talk a little bit about pseudoscience. I have grave concerns about the growing influence of pseudoscientific theories at the federal level of government, and as it relates in particular to autism, but in many respects, whether it be vaccine information or a variety of different types of homeopathic remedies that have been accepted. So we see people, for instance, being replaced on federal commissions who have what would have at previous years been considered fringe scientific ideologies. So based on what's going on federally, I do feel that we have an obligation at the state level to try to continue to provide real science as opposed to pseudoscience. And I'm curious what your department is doing in furtherance of those goals.
Thank you, Representative, for that question. I'm going to talk about vaccines, if it's okay, because I think that has been a huge focus of the department for the last year in response to some disinformation and misinformation that has been coming out. So the Advisory Committee on Immunization Practices has been a longstanding committee that is actually through law required to exist, and the people who are supposed to serve on that committee have to meet very specific training requirements and regulations, and they need to be true scientists with expertise. And as you know, last year the 17-member ACIP committee was disbanded and new committees were appointed, and frankly, many of the people on that committee don't actually meet the criteria that is laid out in legislation around who should be on those committees and what their expertise should be. And as you know, the governor participated with 14 other states on a lawsuit specifically around that committee and the requirements for being on those committee. So we have been working extremely hard to provide education and to put out guidance around vaccines that is evidence-based, that is, I want to be clear, no new science has been introduced to change the recommendations for vaccines, right? There's no new science. The science is the same, and the recommendations, unfortunately, have changed despite no new science.
Lots of citations federally to discredited studies, though.
So with you, we are working extremely hard. The governor did his executive order in October to safeguard vaccines for Pennsylvanians. We were asked to do a number of things at the department. One was to create a single website where all of our vaccine information lives, pa.gov/vaccines. That data is available. We've been promoting that. We also have been meeting with a work group of experts from across the state on how do we make sure we get out science. Our communications team has been working on using best practices around disseminating information. Our videos have been very popular. We asked pediatricians across the state to make videos about the truth about vaccines, and those videos have been popular. I'm also just going to say, as a pediatrician, I've had 30 years of pediatric experience, if you count my residency and all of my work, and I've got to personally see the introduction of new vaccines and the impact they've had on the health of children. So I'm just going to give you a couple of quick examples. When I started practice, we used to, every time a child came in with a fever without a source who was less than age 3, as pediatricians, we would do a spinal tap, a urine culture, and a blood culture, because strep pneumo and Haemophilus influenza type B would be particularly bad actors in that age group, and so we would do this enormous workup to make sure that they didn't have it. Well, after Haemophilus influenza type B and strep pneumo vaccines were introduced, the entire practice of medicine changed, and we stopped having to do that workup if children have those vaccines. So saving dollars and pain to children and families. The rotavirus vaccine, in the first year it was introduced in 2006, cut in half the number of hospitalizations that children had for diarrheal illness less than age 5, and that has continued to decline. As a matter of fact, we rarely now admit a child for rotavirus, and I could go on and on about all of the vaccines that have been effective. And it's very sad for me because parents are trying to do the right thing for their children, right? They have what's best interest. They're just being given information that isn't accurate. And so that is very hard. So I think we have a lot of work ahead. I appreciate your support of science and the evidence, and I'm happy to work with all of you on disseminating accurate information and to tell the stories that I think people need to hear and understand so they can make the best informed decisions for their families.
I might be from the last group of people to have chickenpox scars, so I definitely appreciate the innovation of new vaccines. And if I may ask one last question, Chairman, if you'll indulge me, one quick question, I'm very promise. I would be remiss if I did not inquire when we will see some movement on getting Gaucher disease tested for at birth.
So as you know, I testified at a hearing back in the fall. So Gaucher's was reapplied for. I'm just going to say that you all passed a great law back, I think it was 2019 or 20, making sure that Pennsylvania aligns with the recommended uniform screening practices, which we do. And we have added a couple of conditions based on our committees as well, which is part of the structure you laid out. So our committee that reviews applications outside of the RUSP got put together a subcommittee, and that subcommittee will review the application again and see if there's any new information that would change the decision. And then if they recommend that it be added, then it would go to the full committee at the next meeting. So that committee's been formed. They're trying to find a date. I think they may have a date for that, but we don't, I can't tell you exactly, but it's in the works. I'm happy to get back to you as soon as I know.
I see that my mother has taught the chairman the certain look to give me when it's time to wrap it up. So thank you.
You can tell this is the end of the hearings.
Thank the gentlelady, Representative Nelson.
Thank you, Mr. Chair. Welcome, secretaries. Real quick, I just wanted to thank you again, Secretary Davis Jones, for your visit to Westmoreland County, your support of aftercare. You know, again, a year-over-year decline on our overdose deaths. You know, so it's great to see that's working. My questions are going to continue in the area of maternal mortality. You know, we have your 2025 maternal mortality report before the committee, and in 24-25, the budget had $5 million to address maternal mortality and morbidity. We didn't spend all of that money. You know, it looked like there were about $3 million, 3.4 that was held over, but there's another $2.5 million being requested. What's your intended purpose of these unspent funds?
Sure. I can get back to you with the specifics, but we have just funded a bunch of RFPs that had gone out on those maternal health work. So that data could be updated with that funds. And we have allocated all of the funds that we were issued already. The request for the next $2.5 million is really to focus on the child death review process, as well as, let me explain to you what that is. So
Well, that's okay.
Yeah. So we do, so the money I believe that you're talking about has all been allocated through RFP processes, and the reason it wasn't clear in that some of them were still working their way through the process when you got the budget.
So in this 2025 report, in reading the report, it's showing that Pennsylvania residents, 97 deaths per 100,000. But when we look at the CDC, and again, for decades, or the March of Dimes, they list us at 18.6% for 100,000, which is a stark contrast. And, at first I was confused, and then I got frustrated as I was getting into the report and realizing that Pennsylvania, in this morbidity report, is not following CDC guidelines. I mean, even in your own report on page 7, your first finding, acknowledges approximately 50% of the fatalities were not pregnancy related. So, there's this difference here that CDC, for decades, has been using maternal mortality as during pregnancy or within 42 days, and the death must be related or aggravated by pregnancy. But Pennsylvania, we've created this term, Pennsylvania associated, and we're using pregnancy in up to a year, which then brings in overdose, suicide, murders, cardiomyopathy, and continued mental health conditions. Why does your report not mention this difference?
So the report does explain that there are different, depending on whose criteria you use for maternal mortality, whether you define it as death during pregnancy, delivery, or 42 days postpartum versus the entire year. And there's been a lot of discussions nationally about what should be done. So we have consistently used the up to 1 year postpartum in our analysis and report because, and again, the CDC also has pregnancy-related versus pregnancy-associated. So it is an important distinction to understand.
It is an important distinction. And it makes a big difference because I'm concerned about the priorities. This past Sunday in church, we had a visiting pastor, and, that pastor spoke that the devil rides the fence, So in your report, on page 23, you have 21% of the deaths as rural, 79% as urban. And we're, in a bipartisan way, working to put millions of dollars to reduce preventable death. But there is a contrast between 2021 data, which you're using, and 2026, where we now have 23 counties that are maternity care deserts. How can we be assured that these zones are going to be adequately funded equally?
So we do use our data to make sure that we are thinking about where the funds need to go. And that's why data is so important in the funding decision. The coalitions work across the regions. And we're also looking at the Rural Health Transformation Plan funds really are focused, one of the main categories of that is certain maternal health focused in rural areas. So again, I'm happy to meet with you afterwards and review the report in more detail if that would be helpful. I don't have it in front of me to go through. But I think to be understanding that the Maternal Mortality Review Committee makes recommendations on how we can address maternal mortality issues. And then the funding we've been used to really try to address those. And we are working across the entire state, including in rural areas, on education, on blood pressure monitoring, on all kinds of services for pregnant people and postpartum. So,
and Mr. Chair, I know prior testifiers or questioners on this subject of maternal health were given a little leave. There are two extremely different worlds. When we look at actual maternal death, that is mental health, cardiac or coronary, hemorrhaging, and injuries. When we look, and you mentioned those national groups, when we look at their priorities, that is obesity, 29%, discrimination, 32%, mental health conditions 22%, and overdose 24%. So we need to understand how, in a bipartisan manner, we are investing equally and appropriately for maternal health. Can you understand my concern?
I think I'm losing some of the detail, but what I can say is a death of a mother leaves a child without a mother, whatever the cause. And we need to make sure we're really trying to do all we can to make sure that mothers have the care they need across the entire spectrum, right? And any maternal death is a loss for that family and for that community. So I'm happy to work with you. This is an area where I spent my career as a pediatrician working at the intersection of maternal and child health, and I did a lot of work in pregnancy, and this is a passion area. So if you would like to meet after this hearing and talk about making sure we're distributing funds appropriately, I would be thrilled to have that conversation. It is important that we address all of the issues and that we do it in a fair and even way.
Thank you. I appreciate the latitude, Mr. Chair.
I'm docking you next year. Just put it out there. Putting it on list now. Representative Abney.
Thank you, Mr. Chairman, and thank you to both our secretaries and your staff for being here. I wanted to talk a little bit about last year we passed out of the House Bill 1212, the PA Dads Matter Act, which is currently sitting in the Senate. That is legislation that is designed to have the Department of Health do an education campaign about the important role that fathers play in maternal health. It would also provide some guidance to healthcare practitioners to not necessarily create new programs for fathers, but to figure out how they can be more inclusive of fathers in the programs that they already have for mothers. And I always give the example of I have 2 kids, I have 2 young sons, and during both pregnancies, there are many times we would go to the doctors where I would feel like I'm on an island by myself. I'm sitting in the waiting room waiting to figure out what's going on. I know my wife on both occasions had multiple sessions where she would have sort of like mental health screenings where they would check on her mental health. And I always think, like, I wish somebody would check on my mental health. Like, I want to know, like, people know what's going on with me, how I'm feeling emotionally and physically and mentally, but that never really happened. And so trying to figure out how we can incorporate fathers into those type of programs and activities. So I wanted to see if you could give some insight on the important role that fathers play when it comes to maternal health.
I so appreciate your asking that question. And I'm going to put my pediatrician hat on for a minute because, like you, really making sure that there's families broadly termed, that people have support and get support. And we know actually from the medical literature that fathers also suffer from postpartum depression and anxiety, just like new moms do. So it is an important issue. And for a while in our clinic, we did screen fathers for depression as well and offered that. So again, that's my pediatric hat on. And we did part of a Pittsburgh study that I helped work on. We also screened fathers and found pretty high rates of, again, it's stressful to have a newborn and to go through a pregnancy for all members of the family, right? For the other children, for the support partners. And I think there is a growing understanding that we need to really support not just mothers, but the whole family unit, right? Because the family unit is what provides, and family can define broadly. It could be grandparents, it could be neighbors and friends, but communities really support. And so yes, I appreciate fathers, and as a matter of fact, I think when I first started clinical practice, I didn't have a lot of fathers coming to care, and I really appreciated that over the 30 years I was there, that fathers often, by the way, came alone to pediatric care with their children. So it's really important that we recognize the role of fathers in this process and provide them the support that they need. Happy to think with you about how to do that. I think some opportunities in medical education, but again, not necessarily in the role of the departments specifically, but I think there are real opportunities to make sure people understand what's out there in the literature and the support that people need to be able to be the best parents that they can, right? That's the goal, is that parents are supported to be able to nourish themselves and their children so we have optimal growth and development. And we're happy to work with you on ways to make sure that all parts of the family unit get the support they need so that they can raise and support healthy children to become healthy adults
Thank you. Thank you. I just want to just, in a bipartisan way, reemphasize what Rep. Nelson was talking about. I know there's folks on both sides of the aisle that want to make sure that this administration and the governor is really, lifting up the importance of maternal health and not just talking about it, but actually putting the resources behind it to address the issues in our Commonwealth. Just really quickly, my second question is for Dr. Davis-Jones, Secretary. Thank you. Good to see you again, always.
Yes.
I want to talk a little bit about the stigma around folks who were receiving services and what is DDAP doing in terms of initiatives or programs to try to push back on that stigma that we know still exists and continues to grow.
Yeah, well, thank you for that question. You're absolutely right. Stigma is alive and well. And so one of our major initiatives is our anti-stigma campaign, our Life Unites Us campaign. So for all of the legislators that are still here, if you haven't had an opportunity to go visit our Life Unites Us campaign, please do so. It's lifeunitesus.com. But what I can tell you is we recognize that stigma keeps people from getting the help that they need. And we also know that as a part of our work that we're doing to reduce stigma, we recognize that if we don't get people that have lived experience talking about that recovery is possible and that there is hope, the likelihood of others seeking care is significantly reduced. And so as a part of our work with Penn State University, along with a few other collaborators, we're seeing that individuals in recovery are sharing their stories, and we recognize that through the work of this campaign, individuals that have had an opportunity to review the campaign versus those who have not, they're really seeing the opioid epidemic as a serious problem. And so when you compare the two groups, 75% of the respondents who viewed the campaign versus those that did not really are seeing the opioid epidemic as a serious problem. 85% of the respondents who reviewed the campaign agreed that they would be willing to provide naloxone to family members and friends. And we also do know that for those who view the campaign, they are really saying that it's important that employers should not be allowed to deny employment for a person taking medications for opioid use disorder. And so our goal is to continue to spread the message that recovery is possible, that there is hope. We're using social media. We're using people with lived experience. We have over 360 influencers that are spreading the word. And we're going to continue to uplift the message that services are available and that there's help.
Thank you. Shout out to the social workers out there.
Absolutely.
Thank you, Mr. Chairman.
Thank the gentleman. Representative Reichert.
Thank you, Chairman. We'll try to keep this one short for you. Secretary Davis-Jones, I appreciate everything that DDAP has been doing to help combat the opioid epidemic. There are a few places in this Commonwealth that aren't hit and touched by this. It's my understanding that DDAP contracts currently use name brand naloxone. And I know when a lot of folks go to the pharmacy, pharmacists will instead prescribe the generic, lower cost, same effectiveness, efficacy. But Pennsylvania, I believe, is the only major state that hasn't switched to a generic, and we're one of 9, I think, states that haven't switched to a generic for naloxone, which could save millions of dollars or allow our appropriations to go further and potentially even save more lives. Is this something that DDAP is exploring?
Yes, we're always exploring the cost of our program. We work closely with the Department of General Services to negotiate our contracts, and our goal is to always try to get the cheapest rates as possible. So this is something that we continue to look at. I'm not sure if it's on an annual basis. We do establish contracts with different vendors, but I can tell you that the goal is to always try to think about how we can get the best price for the products that we are offering.
Are we using a generic?
I need to look. I'm not sure.
I don't believe so.
I don't think so.
And
but we just saw a price reduction in in the actual naloxone, and I do believe it could be from competition from generic.
But is the generic still cheaper?
I would need to look at.
I believe it is, and I would encourage you, and if you could certainly follow up with me about when that contract is available. Again, it's an opportunity for us in the Commonwealth to save money or make our dollar go further. Again, these are lives that we can be saving, and if we have generic opportunities out there that have the same efficacy that can save lives, it meets all the same standards, I would highly encourage us to use it. So with that, Mr. Chairman, that's all I have. I yield back the balance of my time.
Good job, sir.
Thank you.
Thank you.
Thank the gentleman, Representative Khan.
Thank you, Chairman Harris. Thank you to both of our secretaries and for your departments for all your hard work. And Dr. Bogan, I just want to thank you for defending the need for safe staffing in nursing homes. I think the question for all of us is, do we want a loved one to be in a facility that does not have adequate staffing? And we know, for example, on the hospital route in Pennsylvania, if we had just what California had, every day we would save 3 lives from dying because we don't have safe staffing standards here in the Commonwealth. I just want to see, do you want to add anything to the importance of safe staffing in our healthcare facilities?
Absolutely. Safe staffing it serves 2 roles. One is patient safety, but also staff burnout. And so we want to make sure that all of our facilities have staffing that meet the needs of patients, but also take care of the staff that are doing really challenging work every day, saving people's lives. And I will say, hospitals and healthcare facilities really care for very sick individuals, right? Who gets admitted to the hospital now, the acuity of care is very high. And so we want to make sure that those people who are dealing with those stressful jobs have support.
Yeah. And in fact, the research shows that the facilities actually, they don't suffer. In fact, more nurses are likely to stay, and healthcare providers are likely to stay because they're not doing more than they can. And it actually doesn't cause hospitals to have untoward effects. So wanted to just uplift that. Wanted to talk a little bit about hospital consolidations. So we're seeing a really problematic trend with these private equity and for-profit groups that are buying up hospitals. There was a recent Gallup poll that showed that 1 in 3 Americans are actually skipping meals and other necessities to afford health care. 1 in 3 Americans. Meanwhile, we have private equity firms and for-profit corporations that are making hundreds of millions of dollars, and the hospitals that they're buying and health facilities that they're buying are struggling because they're extracting those profits. We have legislation here in Pennsylvania. Representative Borowski is leading it, and also I'm a co-prime on it, and I think all the Democratic members in the Delaware County delegation are co-sponsors as well, or co-prime sponsors on it, that we give the AG powers to really rein in the abuses of these private equity when it comes to hospital mergers and consolidations and acquisitions. Can you talk about the importance of giving the AG that power to rein in this abusive practices that we're seeing with these for-profit corporations?
Yeah, you did such a good job explaining the situation. Thank you. Yeah, we have seen challenges around for-profit and other challenges with our house. Let me back up. We have our hospital closures that have resulted from the use of some private equity related purchasing. The department's role really is currently around licensing and permitting, but we do have would be thrilled to work with you around authority to assure we can have the tools we need to enforce and ensure, like we have with the long-term care facilities. So with the long-term care facility legislation that was passed, regulations that were passed, we examine fiscal responsibility and things like that. So we would love to talk to you about the responsibilities we can have and work with you on how to make sure that we can review the hospital as well as making sure we're bringing in owners and operators that can provide the services that they say, and that they're there for the long term and provide quality of care. And it's important that we work together on that, because there are certainly hospital closures that we've seen and challenges we've seen over the last couple of years that are impacting access to care. And we would like to work with you all to make sure that continues to, that we continue to work together on that.
Yeah, and I'll just close that out with just saying we've actually seen, and this is a bipartisan issue, we have in the Senate, U.S. Senate, Chuck Grassley and White House working together, calling out some of these really bad actors: Apollo Global Management, Prospect Medical. We saw what happened in Chester County, closing of those hospitals. So
yeah, I know that it's an issue for the governor as well, that he's interested in making sure that we bring in operators that will be reliable and provide quality of care for all Pennsylvanians. So we do need to work on this together to make sure we have all the tools we can to ensure that.
Thank you. Thank you, Chairman.
Thank the gentleman. Representative Vanzo.
Thank you, Chairman Harris, and thank you all for being here today. My question goes out to Secretary Davis-Jones on the opioid settlement. Secretary, Pennsylvania is expected to receive nearly $2 billion from the opioid settlement agreements, with about 70% going directly to the counties and local governments. These funds were meant to address the damage caused by the opioid crisis. Secretary, back 2 years ago, I was at a night out in one of my communities, and my daughter come up to me at the end of the night, and there was a bag full of candy, and in that bag was a inhaler. And so is that, I guess my question is, what oversight does the Commonwealth have to make sure that, with this Narcan, is that a good use of the Narcan in a bag with a Reese cup going out to the kids? At the end of the night, I gave it to our local police chief, and he took it back. And I really didn't dive into this trust fund until shortly after this. So could you just touch on what oversight you have over it?
So I think you're asking, you talked about an experience that your daughter had, I guess, naloxone with a treat in a bag. And is it, from your perspective, that product came from the opioid settlement funds?
Yeah, yes.
Well, I can tell you that currently here in the Commonwealth, we use our state opioid response funds to support our overdose prevention program. We have 100 partners across the Commonwealth, and we try to ensure that naloxone, brand name Narcan, gets into the hands of those that need it the most. Why it was in a treat bag for a kid is unbeknownst to me. I don't know why that would be the case. However, the goal is to always target and ensure that we're getting naloxone in the hands of those that are at highest risk for overdose, and then also ensuring that family members and loved ones or anyone else within perhaps one's social network can have access to it as well, because as you know, an individual can't use naloxone on themselves. It has to be someone that's witnessing the overdose. So again, from the perspective of what oversight do we have, there is the Opioid Trust, who has the responsibility of monitoring those funds that are distributed to the counties, which is 85% of the funds, and then the 15% that comes to us. So again, we're not using it, and if a county would like to purchase naloxone, that is a permissible use under Exhibit E for counties to use, to use those funds for. But again, about it being in a bag or being given to children, I can't really speak to that.
Yeah. So talk about the structure a little bit. The 70% that goes to the counties. The counties have the sole discretion to dispense that 70%, or do some of those have to come back to the trust?
No, the counties in litigating subdivisions, which is equivalent to 85% of those opioid settlement funds, it is up to the county to decide how to use those funds as long as they're in alignment with Exhibit E. Now, what the trust has the ability to do is every single year the trust will review how those funds are spent, and then the trust will say whether or not those activities are allowable or disallowed. And if disallowed, then the county will owe back those funds or will not be given those funds in the next fiscal year.
Okay. I get a lot of questions on this from my police chiefs back in my district. So is there I know the last time I went on a website, we could see what grants were awarded, some of the expenditures, but it wasn't year to year. It was like all the way back from 23, 24, I believe. Is there a report out there that we could have access to, or some of the expenditures?
Is this for the opioid settlement funds?
Yeah.
If you go to the Opioid Trust website, there's lots of information that shares what is happening within the counties, the funds spent. So I don't have the website offhand, but there is a website that really is detailed and shares lots of information about how those funds are expended.
All right. I have one more question, but I'm going to submit it for the time here. So Chairman Harris, look at that smile right there. So thank you.
Thank the gentleman. Representative Webster.
Chairman, thank you. And Secretary, thank you both for being here. It is late in the afternoon, but I guess we're getting a little carried away. Previously, and I'll point two chairs in front of me here, my female colleague would let you know every time that she's a nurse and she's from Scranton. I'm not a nurse. My mother was a nurse for 38 years in the maternity ward in Roxborough Memorial Hospital. And so we talk about the other nurse in the room and his area of Philadelphia today. I think that leads, and I'm just sort of endorsing, I want you to know the support you have for nurses, for the workforce issue and stipends, for maternal issues. Like that maternity ward at Roxborough Hospital doesn't exist any longer. It was bought and sold, the hospital. We know those issues. So I'm refocusing on that private equity issue and want to talk about that a little bit. I was at a conference this summer with the attorney generals from Massachusetts, from New York, and from Rhode Island. And their strongest recommendation was make sure the attorney general in Pennsylvania has the authority to evaluate these acquisitions and mergers. Is that something that you support as a department for Pennsylvania?
Again, I think, the governor has talked about how important it is that as a state that we can make sure that we have operators of our healthcare facilities that are committed to the community and that they put the patients before profits. And so I think we need to do all that we can to make sure that we have the tools in our toolbox to make sure that that happens. Yeah. So happy to talk to you and anyone about how we can work together to ensure that we have the controls that we need, the tools that we need to ensure that our providers are doing what they need to do to take care of patients and not abandon them and leave them uncovered for care.
My understanding, as we sort of peel back the onion, right, that these private equity firms are now moving into specialty practices in oncology and gastrointestinal practices, and they're so cash rich that they're buying up these other pieces. And I know in Montgomery County, Pennsylvania, there's really only one gastrointestinal community you can go to. So it becomes a monopoly system rather than a service system. Are you tracking those same kinds of things through the department or seeing trends in those ways?
So the department oversees the licensure of facilities. We don't oversee the licensure of private practices, right? Those really fall under the individual physician license, which falls under the Department of State. So we don't track practice specifically around access. The other issue is that the insurance commissioner does some work on adequacy issues to making sure there's adequacy of services, but that doesn't really fall to the Department of Health around individual, like for instance, a dermatology practice or a pediatric practice that falls under the Department of State under the physician license. We really license hospitals, ambulatory surgical facilities, long-term care, skilled nursing facilities, and the like.
I know, and
Sorry,
yes,
if I could
please.
just add
Yeah.
to that, there are some instances where there are outpatient facilities associated with a hospital license, in addition to what the Secretary said. So there could be a case where, there's a closure of a hospital that also had outpatient facilities that also close. And I think to your point about, oversight from the Attorney General's office, the Department of Health has oversight of the operators, and we regulate the operators, and we can look at kind of the ownership structure within that framework and look at the finances in that sense when there's mergers or change of ownership. But our authority only goes so far, so we can't, control really the ownership.
It resonates with me to hear that, and I'm thinking immediately that we're looking at some sort of systemic issues that I mentioned nurses when we started, right? You have nurses, a Department of Education has nurses, our Department of Corrections has nurses, yes. And I'm not sure we're looking at it as a workforce issue across the board. In this case, with the private equity things, government's not prepared because we have licensing and authorities in different places, and it sounds like we need to think.
I do think the governor really is thinking across all of working together. So, but Kristen's point is right. Many outpatient facilities fall under a hospital license that would fall to us. So I appreciate that clarification. And the clarification, I think Kristen's point really is operators and owners are different. And we need to make sure that as you consider your options around authority and control, to make sure that we consider what we can do around that difference and to really make sure people understand the difference.
Yeah, and I know it's not simple, but we appreciate all the effort we can get to provide health and medical services rather than business transactions.
And I would be remiss if I didn't do a shout out for nurses too, since my mother-in-law's a nurse, my sister-in-law's a nurse, and I have a daughter who's a nurse. So yes, shout out to the nurses.
Thank the gentleman, Representative Rigby.
Thank you, Chairman Harris. Sorry I can't shout out. I don't have any family members that are nurses, but wish I did.
They take good care of you, that's what I can say. They're caregivers.
Madam Secretary, I'd like to direct you attention to page H37 of the Governor's Executive Budget, which shows the Emergency Medical Services Operating Fund. Beginning in the current fiscal year, an additional $6 million is transferred to your department for disbursement to regional EMS councils for recruitment and retention efforts. Are you drawing down on that cash balance for the account? Are you drawing down on the cash balance of that account to fund this effort?
Yes. The MSOF fund had accumulated more money in its account due to increases in the collection of fees, and we wanted to make sure that money gets back out and is used. So we are using those funds to fund a number of projects related to, that goes through the regional councils, to the agencies to do workforce recruitment, education, and equipment, yes.
It appears that the ending cash balance of the account at the end of fiscal year 26-27 would be approximately $9.8 million. Do you plan to continue this initiative through 27-28?
Yes, we have it in the proposed budget for this year, and it was originally a 3-year spend down to make sure that the money could be used most effectively. And we've been working really closely with the regional councils on what that should look like. And I'm really happy to say I was just out in Allegheny County at an event talking about how, for instance, one of the EMS West was using it to distribute and make sure that all of the ambulances that have ALS can use a video laryngoscope, which is actually a really amazing tool to make sure that people improve first pass intubation techniques, and they are have an equitable way they're purchasing and distributing those and making sure all of the ambulances that are across the entire EMS West footprint have these tools. So that's an example of how some of the funds have been used by just one regional council. But it is important that this money be distributed over time so that they can get it out and used most effectively.
I was going to ask what the allowable uses was for this funding, but I think you covered some of that. Do you have any metrics on the data to prove that this funding has been successful in these efforts? And again, I think if we're talking about the West and we're getting those pieces of equipment out, it certainly is working. The Auditor General, Tim DeFore, released a performance audit of the Emergency Medical Services Operating Fund in November of 2025 that found your department failed to adequately monitor the Emergency Medical Services Operating Fund and failed to strengthen initial controls identified in the previous audits. Specifically, 68% of the expenditures lacked the supporting documentation needed to verify funds that were spent for allowable purposes. Has your department contacted or corrected these issues, and how can we be sure that the new retention and recruitment funding will be spent appropriately?
Thank you. I really appreciate the opportunity to talk about this important fund. So I just want to be clear. I know there have been some reports out there that money is missing. No money is missing. Every penny went out to the regional councils, and the issue was really around documentation. So I'd like to give you a brief history. So when I arrived as a Secretary of Health in 2023, I received shortly after my arrival the MSOF audit, which is required by law, for the 2018 to 21 year. So it's a 2-year delay in the audit. I received that in, I think, March or so, roughly, of 2023, and I met with our team right away. Kristen and I and our deputy went out to all the regional councils to have discussions, figure out what was going on, and really we put in place a response to the audit, as well as to really repair the challenges that were between the department and the regional councils. And that's been fixed, which is great. We're working really well with the regional councils. So by the end of 2023, we had in place fiscal management, that we had developed new software for tracking. We had worked with the regional councils on implementing it. We implemented all the training, and that happened over the year. And by the end of 2024, everything was in place. The problem is that the next audit that was done covered 2021 to 2024. So 2 years of which I had no ability to make any change to the prior audit. And so I'm thrilled to tell you that we will not see these challenges again, because we've addressed all of the issues in the audit over the last couple of years, and we have in place really careful control measures. Again, no money is missing. It was just really a documentation issue, and we have resolved all of the challenges around documentation. So I am confident that our next MSOF report, which will reflect the time that we have been addressing the issues, will not reflect the same challenges. And it's been really our pleasure to work with the regional councils. I want to give a shout out to them because they've been great to work with. They all understand the challenges that we are faced, and they appreciate that we are working on this together. So thank you for the opportunity to talk about that.
I appreciate that. I'm a big supporter of our EMS, and I want to make sure that they're getting their funding due. Thank you. Thank you,
Thank
Chairman.
you so much.
Thank the gentleman. Representative Fleming.
Thank you, Mr. Chairman. Good afternoon, Dr. Bogan, Dr. Davis-Jones. Thank you very much for giving us your time. I want to talk about something that is really pertinent to my family, as well as thousands of other families across the Commonwealth, and that's the school health services reimbursement. That reimbursement has remained flat funded since 1991. While the number of students with complex medical needs, chronic conditions, and behavioral health challenges has increased significantly, including, our daughter, who I've spoken about many times. She's a type 1 diabetic, and so that condition requires management throughout the day, throughout the week, at all times. And oftentimes, she is changing her CGM or changing her pod at school with the assistance of a wonderfully competent and capable middle school nurse. And so I am grateful for school health services that are provided. I'm grateful that, my home school district does invest in robust school nursing care throughout each of its buildings. I know this isn't the reality for everybody else. So can the department quantify the gap between the current state reimbursement and the actual cost to school entities to provide these services?
Yes, I appreciate that. And again, another shout out to nurses and the importance of nurses in our healthcare system, including in our schools. So as you alluded to, we do have many schools have school nurses, but we know that there are not enough. It's been about 35 years since the reimbursement rates have really been updated. And I think the other really important point is that the number of students in our schools that need nursing services, complex nursing services like diabetes management, seizure management, a variety, catheterizations, concussion monitoring, blood pressure monitoring. I know I certainly sent many of my students with prescriptions to the school nurses to monitor things like blood pressure. Those have really increased. And when you compare 2015-16 school year to 2023-24, we've seen a 66% increase in students needing complex care for nurses, with a 3.8% decrease in the total number of students So we're seeing fewer students, but more complexity. And really, our reimbursement has not kept up with that need. So I think we have seen about a 31% decrease in the amount of overall cost coverage in that time period as well. So would love to consider and figure out how we make sure that our students that are relying on these services have school nurses available to them. And again, funding is definitely a challenge, and reimbursement. So again, important discussion we all need to have.
Yeah, and we will absolutely do so. I think, you know, there's nothing more fundamentally important than making sure that students can access health care while at school. And then the last thing I want to say is for Dr. Davis-Jones, I really appreciate your presence in the Capital Region. I've been privileged to attend a number of events where the Department of Drug and Alcohol Services, or the Department of Drug and Alcohol Programs, is here in the Capital Region, and your partnership with the Dauphin County Drug and Alcohol Department is really top-notch. So I just want to say thank you so much for the work that you're doing across the state, but particularly here in the Capital Region. And thank you for the naloxone for my office. We've actually distributed three doses in my district office since I saw you a couple of years ago and was able to get that from you. So thank you so much. Thank you, Mr. Chairman.
Thank the gentleman, Representative Mattson.
All right, I have a very quick question. Basically, I'm just, first of all, good afternoon, and thank you so much for coming today and answering all our questions, and thank you for all you do for the Commonwealth of Pennsylvania. I just want to piggyback off of Chair Frankel's question or statement regarding the high-efficiency air purifiers. I'm actually very interested in working with folks in my district to make sure that they acquire these. So how is the best way, or what are the next steps we can take to make sure that everybody in our districts has an opportunity? We want to support you in getting these out and making sure that our this technology is being used throughout our districts.
Yes, I appreciate that. You know, again, this was a process we went through over a couple of years, creating the lists, reaching out to people. We reached out to all the folks on the list multiple times of their interest. The money is, I have to get back to you on how much more time we have to get that funding out. So if it'll be okay, we'll work with you after the hearing to make sure we provide information we can about what we have left to do to get this.
Yeah, absolutely. And if there was nobody in my district that got back to you, I just want to follow up with them personally just to make sure that they let you know and they're not missing out.
I appreciate that. Thank you.
Thank you. That was it.
Thank you.
And thank you, Rep. Fleming, for the kind words.
Thank the gentleman, Chairman Struzzi.
Thank you, Chairman Harris. Just to wrap things up, I appreciate y'all being here. I appreciate the Secretary coming out to Indiana for the Rural Health Care Conference back in the fall, along with Secretary Arkush. You know, I really, I think we highlighted a lot of stuff today. We clearly have challenges in healthcare, particularly in the rural areas, but I also believe that working together we can find solutions. So I think it's important that you do come out to the rural areas, that we talk about solutions, not necessarily pointing fingers, but working together to collaboratively approach new and innovative ways to make sure that people are getting health care in every corner of this Commonwealth. So I appreciate all that you do. I appreciate our first responders, our healthcare workers, and everyone out there that's taking care of those in need. And then to wrap things up for these budget hearings, Chairman Harris, I appreciate your flexibility with the speakers throughout these 2.5 weeks, I guess. Through all of these hearings, I appreciate that as a referee, you did not actually throw the flag at anyone. You know, we all understand it's been a long journey, but we also understand that this is the next step in the process of working together to create a budget for this Commonwealth that is responsible with taxpayer dollars, but also meets the needs of our constituents and the people of this Commonwealth. And hopefully we can get that done by June 30th. So thank you all for being here. Thank you to all the committee members, although not many are left. We appreciate your commitment as well, and the staff. There's a lot that goes on, not just in these hearings, but behind the scenes, and we appreciate everyone's commitment to this process because it is important and it is for the people of this great state. So thank you.
Thank the gentleman, and I thank Secretaries Bogan and Davis-Jones for being here, for the work that you do, for the 13 million or so people that live in this Commonwealth, and to all of your staff and all of the folks at the departments that you lead. I do want to echo the chairman's sentiments. I think, we have different ideologies or policy disagreements, and that's fine. I honestly believe that a healthy government is one with political discourse. You can disagree without being disagreeable. And far too often in our body politic today, I think we don't see enough of that. And so I've tried my best over the last 2 weeks to give everyone room to share their perspective, ask their questions, but do so in a way that was respectful to the dignity of the chamber and of the work that we do. And I hope that we achieve that goal. And I hope that the people of the Commonwealth, if you don't have anything to do and you can't go to sleep at night, go back and watch the budget hearing. You'll learn a lot. You actually will learn a lot. No, seriously though, over the last few days, few weeks, we've had experts in their field come in front of this committee and answer questions on the dollars and cents, the taxpayer dollars and cents that will be expended for the benefit of the people of this Commonwealth. So I am grateful for all of the work of the committee members, the staff from the agencies, staff from the administration, as we embark upon this next part of the budgetary journey. And with that, budget hearings of 2026 are now closed. Thank you, everybody.